So we're going to talk about two endocrine emergencies, hypocalcemia and acute adrenal insufficiency. And I have listed here the endocrine emergencies, just basically all the endocrine emergencies that are life-threatening, potentially life-threatening, and can require an emergency hospitalization. So overall, endocrine emergencies constitute about less than 2% of all hospital emergency admissions. And therefore, many physicians are not, really don't have adequate exposure to endocrine emergencies and don't really have the confidence to effectively manage the most complicated cases. And what I mean by most complicated are pretty much the APS1 cases, because many of the APS1 cases have more than one endocrinopathy. So having adrenal insufficiency and hypocalcemia together, and sometimes there's also hypoglycemia as well. Some of you even have type 1 diabetes. And so it's very hard for the physician to sort out what is going on and to treat multiple emergencies at one time in different organ systems. So these are the symptoms, and the symptoms are very nonspecific. For example, fatigue and dehydration can mean Addison's, it can mean hypoparathyroidism, and it can also mean that diabetes. These are all very nonspecific. Hypopara, though, tetany, cramping, paresthesias of the perioral paresthesias, the hands and feet, that is very specific for hypocalcemia. Nausea, vomiting, also Addison's. Many patients with Addison's and diabetes get these symptoms. Polyuria, if you're urinating a lot, that could mean hypercalcemia or diabetes. A diabetic that's not treated well can have polyuria because of all the glucose that they're excreting in the urine. And so many of these emergencies are precipitated by infections, and not caused by the infection, but precipitated by infection. That's why we often tell patients that during a febrile illness to change their approach to their illness a little bit and change what they're taking. I often tell patients to increase the calcium and calcitriol dose, but you really have to discuss this with your doctor first, and because everybody's different, and also there's a chance of over-treatment and becoming hypercalcemic. Also, one needs to maintain adequate hydration, and if you're unable to take oral medication and you really aren't eating, you really should seek medical attention for IV calcium. So what does one do at home when you start getting the tetany, the paresthesias, the cramping? Obviously, part of your treatment, we discuss what foods contain calcium. There's calcium fortified orange juice, yogurt, cheese, milk, all these things. Everybody has their favorite foods, and that's something that is very bioavailable, and you should do that when you get mild symptoms. Obviously, calcitriol and calcium. Ask your doctor if you should take more of that. If you have PTH, that's wonderful, because that often really is the answer. That helps. Everybody should have some sort of identification on them about what disorder they have, Addison's, whether it be Addison's, diabetes, hypoparathyroidism. If you have to go into the emergency room, the treatment of choice for hypocalcemia is calcium gluconate. PTH is ideal. PTH is to hypoparathyroidism as steroids would be to Addison's disease. So if you have PTH, definitely use it and bring it with you to the emergency room. Don't leave it at home. So what happens when you get to the emergency room? Immediately blood work is obtained, blood pressure and so forth. Electrolytes and mineral panel, albumin, and certain things to assess, markers to assess if you're dehydrated and how dehydrated you are. So alterations in albumin due to malabsorption or other things can affect the calcium. So you do have to correct the calcium for the level of albumin. Often the doctor will get ionized calcium, which will be much more accurate. And 25-hydroxy-D and 125-hydroxy-D, it's not something that must be done immediately, but usually they do that because the differential for hypocalcemia is severe vitamin D deficiency. So the management of severe hypocalcemia in the emergency room for an adult would be about 1 gram of calcium gluconate IV, and this should be given over about 30 to 60 minutes. Many people in the emergency room get this over a very short period of time, but often the kidneys, especially in a hypopara patient, cannot really handle such a large load of calcium because it causes unopposed hypercalciuria. And what do I mean by unopposed hypercalciuria? It means that you don't have PTH to reabsorb the calcium in the tubule. So giving it over a shorter period of time longer period of time is better. The bolus will cause a temporary rise in serum calcium, so it only lasts a couple of hours. So initially what you're trying to do is to reduce the symptoms, not necessarily bring everything to the normal range, because it's not going to happen with one bolus. Also, many patients with hypoparathyroidism also have hypomagnesemia. And so the magnesium has to be also corrected, and that's usually done with IV fluids, IV magnesium infusion and fluids. So the treatment goals for acute hypocalcemia, the treatment goals for hypocalcemia do not really align with the treatment goals for adrenal crisis, and we're going to hear about that in a moment. With adrenal crisis, we need to give large amounts of sodium, and sodium actually potentiates the excretion of calcium in the tubule, and so it's actually a treatment for hypercalcemia is normal saline. So reduction of symptoms should be the primary therapeutic goal, as I just said, rather than bringing the calcium into the normal range. And repletion to the normal range will lead to hypercalciuria, and if done repeatedly, this can lead to nephrocalcinosis and nephrolithiasis. And children under 16 really need to receive weight-adjusted calcium doses. So a young child doesn't need 1 gram of calcium bolus, and often doctors in the ER will do this, and it's really not necessary. A small child, say a 4 or 5-year-old, only needs about 200 milligrams for a bolus of calcium, and that can be repeated. Okay, I think that's it, and we're going to go to Addison's now.
Okay, so I only have 7 slides, and I'm trying to give a big picture description here. I realize I'm an adult endocrinologist. I take care of adults, and I realize a lot of you are parents who have kids that have this, and I'm going to try to, cover both sides of the coin with what I say. So the first thing is, what is an adrenal crisis? People who don't make any cortisol, they don't just they just don't have an adrenal crisis out of nowhere. It has to be precipitated by some other illness. I think that's the first thing you got to understand. It's not, I'm having an adrenal crisis because my cortisol is low. No, you're having an adrenal crisis because you're sick and your cortisol is low, okay? Because cortisol is a stress hormone. It normally rises with a physical stress, and I'm not, and so this would be fluid loss or blood loss, low glucose, infection, or a major surgery, okay? So it's basically adrenal insufficiency plus a significant illness. Because you're not making cortisol, your cortisol doesn't go up, and that absence of cortisol prevents the bodies from responding to the stress. And in particular, the adrenaline that's made from not just the adrenal, but also from the other parts of the nervous system, try to make the blood vessels contract to keep your blood pressure up. But they can't do that if there's no cortisol. All right? So cortisol has a permissive role in responding to adrenaline, or catecholamines is the other term for it. So you get low blood pressure and glucose. You don't perfuse your organs like your brain and your liver and your kidneys, and that can be fatal if it's not treated. So that's what an adrenal crisis is. So the management, there's three things that got to be done. Volume repletion. You got to get the blood volume up. Okay, and for that you need to use, as Karen mentioned, intravenous normal saline as fast as you can. You know, well, again, in an adult, not 100 cc's per minute, as fast as you can, 500 cc's per minute. Just blow it in, squeeze the bag, you know, all that stuff. So as big an IV as you can get in as fast as you can. And small children, they can do intraosseous. If they have trouble getting an IV, they can put a needle into the shin and give it that way. Now, once you're stable, oral sodium chloride is fine, but that would mean like salty drinks, so like beef broth or some sort of broth or sports drinks. Don't have as much sodium, but they're good for mild problems. So kind of again, like the hypocalcemic crisis, you gotta fix the problem and then maintain it, okay, at a slower rate. So there's sort of two phases to the treatment. So that's the volume status. There's the steroid replacement, which is usually intravenous hydrocortisone. Intramuscular also works fine. That's your Solu-Cortef. You give that intramuscularly. Now, there's other drugs, and one of my main points that I'm going to kind of cover today is, you know, we all tell people to take your Solu-Cortef and stuff. If you go to the emergency room and they say they're going to give something else, I don't want you to argue with them, okay? Because you want to give something as quickly as possible, and I'll explain what the other medications are. They're not as good, but anything that's a glucocorticoid, that's a cortisol replacement, is better than nothing. So if they don't have Solu-Cortef ready, but they have dexamethasone, take the dexamethasone, all right? That first dose is the critical dose. So just whatever you can get that as soon as possible. And then the third step is to determine the precipitating factor. Why did you go into an adrenal crisis? And you have to treat that separately. So if it was that, again, in our APECED patients, if it's because their esophageal candidiasis is out of control, and that's why they're throwing up, well, you got to treat that, or otherwise they're going to have another adrenal crisis after I get them back out of the hospital, okay? If there's a GI illness, we've got to treat that, or we've got to continue them in the hospital until that resolves. So let's break this down to the three steps: the volume repletion, normal saline or dextrose normal saline, particularly in children who are prone to getting hypoglycemia from an adrenal crisis. Put some glucose in the bag. You sort of estimate the deficiency and then try to give 2/3 to 3/4 of that as soon as possible, and the rest can be slower. You titrate to a normal standing blood pressure. If they can't get up out of the bed and walk around with a normal blood pressure, they're not treated enough. So keep it going until they can stand up with a normal blood pressure. And then orally, things like, you know, like I said, beef broth, chicken broth, and for those of you who are vegetarians, vegetable broth is perfectly fine. There are the electrolyte mixes like Pedialyte, and then there's sports drinks like, you know, Gatorade, not the diet kind, the one with glucose in it, Gatorade, Powerade, those things have less salt than the broth does, but they're they're good for at home, trying to avoid going into trouble when you have mild illness. You know, you have a choice of these things. So again, the point is that hydrocortisone alone will not correct the loss. If you lost 4 liters and I give you hydrocortisone in 100 cc's, I've only given you 100 cc's. I still need the other 4.9 liters, and that has to come from the normal saline or from something you eat or drink. So you have to do the two together, all right? You know, usually the volume first, and then as soon as the IV is going and the volume is coming, is starting to come in, then you give that first dose of hydrocortisone. All right, so hydrocortisone, you know, IV or IM, that's Solu-Cortef, that's best for an adult or a large teen. It's usually 50 to 100 milligrams every 6 to 8 hours. That's actually probably more than you need, but you know, I actually usually give I give 50 milligrams and then I follow that with 25 milligrams every 6 hours. You know, I prefer to give a smaller dose more frequently than large doses infrequently, but the first dose should be a loading dose. In infants and preschool children, 25 milligrams is the most you would ever need, and again, every 6 to 8 hours. Now, the other thing that can be given intravenously is methylprednisolone, which goes by Solumedrol, and it's about 5 times as potent, has a longer half-life, so you proportionally reduce the dose 10 or 20 milligrams, no more than every 8 hours, and then about half that for an infant or a preschool child. Dexamethasone is about 5 times more potent than methylprednisolone, so you only need a couple of milligrams of dexamethasone under any circumstances, and you only need to give it once or twice a day. And that also goes by Decadron. So if somebody says, well, we got Decadron, you know, if you come to an emergency where you're on an ambulance and they say, well, all we got is Decadron, well, take the Decadron, okay? But, you know, and then switch it over when you have the opportunity. And then third is identify the precipitating factor. Now again, you know, you may hear diabetics that go into ketoacidosis because they missed a dose of insulin. You don't just go into an adrenal crisis because you missed a dose of hydrocortisone. It just doesn't happen. There has to be something like an infection. Often it's a gastrointestinal infection because that's a way that you lose fluid and fail to replace it because it's affecting where you eat and drink. And then other things, any kind of sepsis, pneumonia, your major infection, encephalitis, and things like that. The other way to lose a lot of fluids is hemorrhage. It can be internal or external. So car accident, bleeding into the bowels, if there's significant ulcers or things like that, you can lose a lot of blood that way. Cardiovascular problems like a heart attack or myocarditis, rare, but they do happen, especially as people get older. And then finally, environmental, and that would mean like high levels of activity in extreme climate. So, you know, some of you will become marathon runners, and you know, good for you. But if you're running the Houston Marathon, you know, if you don't. You know, there was a crazy time when people were told that they shouldn't drink water during long distance running events, and not, I'm just talking about people with adrenal insufficiency, but there was this concern that people were over drinking, and so we had our patients going out and not drinking, and it was like, no, you do need to keep your volume up. But you know, even like I had one patient with adrenal insufficiency that had an adrenal crisis playing golf in Texas in the summer, okay, because it was 104 degrees, and even though he was trying to eat and drink, he was just losing fluid faster. He was a heavy sweater, especially in dry climate. You don't notice what you're losing. In fact, like if you're bike riding in very dry climate, you lose a ton of fluid, but you don't see it because it evaporates so quickly. So you got to be cautious about that. So one of my, you know, the ways that I try to educate people is, you know, the warning signs. The warning signs are high fever, vomiting, diarrhea. I'm losing fluid faster than I can replace it. Those are the things that I think. I'm lightheaded. I stand up, I feel dizzy, and I can't take my pills, or nausea. Those are, anytime any of those things happen, you should sort of get your dander up and start thinking, I may be going in the wrong direction here. So we usually tell, and different endocrinologists have different ways of doing this, but you sort of double or triple your normal hydrocortisone dose for these sort of illnesses where I'm sick, but I can still eat and drink. So I'm still able to maintain my fluid status, but I'm not as well off as I usually should be. So if you can still eat and drink and take your pills, you double or triple your hydrocortisone dose. And there are some alternatives. So for example, there are some liquid forms, like dexamethasone and prednisolone actually come in liquids. And so you can suck on a small dose of liquid prednisolone to get your dose in where you couldn't get a hydrocortisone pill down because you're gagging on the pills. And then the last step is if you can't take anything, you take your Solu-Cortef injection and then go to the hospital. So I try to tell people that it's not that the injection is not to keep you out of the hospital. It's to get you to the hospital. Okay? All right. And so, because that's only going to last about 4 hours. All right. So if you're that sick, you should probably go to the emergency room. Now, once in a while, people who have been around the block a long time, they'll be able to take it, and then all of a sudden they feel much better, and they're able to eat and drink and take their pills, and then, okay, fine, you don't have to go to the hospital. But just in the beginning, when people are first dealing with this situation, you err on the side of caution. You take your shot, and you've got 4 hours to get to the emergency room. So the cardinal rules of adrenal insufficiency: any gastrointestinal illness should concern you. Okay, again, but as long as you're keeping your pills down and keeping up with the fluids, you're okay. A little bit on the more sick side, double your dose. Can't take anything at all, you take your injection and go to the hospital. Okay, and this is one of those things that people just learn over time. Fluid loss faster than restoration can equal a crisis. All right. Know your favorite salt-containing liquids. So when you start to get feeling like that you know, I like blueberry Powerade and I like, whatever soup or what, Campbell's chicken noodle soup or whatever. And then know your sick day rules, whether your endocrinologist wants you to double your dose or triple your dose or switch to prednisolone or what. Taking your Solu-Cortef generally means a trip to the hospital. And bring your Solu-Cortef with you, okay? Because a lot of times, if you're taking somebody, if you say, well, we're just a block away from the hospital, and we're five minutes from the hospital, and I don't need to give the injection, they'll do it there. No, bring it with you, because they may not have it available, they may not know what to do it, and the EMS trucks usually don't have it. And they're often not trained how to give it. So many a parent of a child with adrenal insufficiency has had to stand there and give the hydrocortisone in front of the EMS people because they aren't trained to do it. All right, so bring it with you. And then take whatever you can get in an emergency. Again, don't say, no, I'm not taking the Solumedrol. No, take the Solumedrol, all right, and then move on to the next step. Okay.